All right, thank you. So I also like to invite you to change your Zoom name to the following to this format. So you can put your name followed by your pronouns if you're comfortable sharing, and then also your organization. So this will help us identify and also address the questions later on. And we also invite you to mute your microphones when not speaking. If you are also comfortable turning on your cameras. So that's also helpful for us so that we can have a interactive session. You can also use emojis, raise hands function if you want to ask questions, especially if you have technical issues. So hopefully everyone is able to hear me well, no? And you can also utilize the chat function if you have questions. No, I also see some participants already using the chat function to introduce themselves. So please do so. Please keep the chat box active so that we can get to know each other, even if it's just online. So this session will be conducted in the following languages: English, French, Khmer, and Bahasa. And as always, we want to make sure that this is a safe space. So let's make sure to contribute as well as listen to each other's inputs. And some of us might be just first timers in terms of doing the Zoom. So please look at the bottom part of your Zoom if you want to change to the channel that you want to listen in. No? So you can click the interpreter logo at the lower hand of your screen, and then you just select the language that you're most comfortable in. All right. So now, just to break the ice before we formally start with our session, I'd like to invite you to join this icebreaker in Kahoot. So you just need to scan this QR code and then enter this pin that you see on the screen. So once you enter uh, the the Kahoot interface, you should be able to see something like this. Let me share that again. Okay. So hopefully you're able to see this one in your screen. So let me know if you're having challenges with the Kahoot. So I think it also works if you're using a phone to join in. All right. So I see some people already joining. So okay, good. Thank you, Jeff, for also sharing the website as well as the pin on the chat. So kindly be creative with the name that you're using. And then what we'll do here is that we will flash some questions related to our topic today. And then you click on the correct answer. So the earlier that you click the correct answer, the higher the points that you'll get. And please note that there might be questions with one or more answers. So some questions might have two correct answers. So of course you have to get, for example, if the correct answer to that question is two, then you have to get the two answers correctly, no? So that you can get the full point. So please let me know if there are challenges. Kith, are you still having a difficulty joining? So far, we have 17 participants in the Kahoot. So we'll just wait for some more. Currently, we're 81 in the call. So hopefully we can have more participants. Okay, so that's good to hear, Kith. So let's try to reach at least half of 81. As much as possible, we want to get as many participants as possible so that it will be very competitive. So the questions are related to our topic. So community-led something because that will be one of the questions. Okay, so we're still waiting for some more. I'll wait for 1 more minute and then I'll start the session.
Good
Okay,
morning. Good morning.
good
I'm
morning.
Abdullah Ibrahim.
Okay, we have 25 participants, 26. Okay, we have 29. So just waiting for that minute to pass so we can start. Okay, so I think we'll start already. So please make sure that you have a good internet connection. Okay, so first question, what does CLM mean? So kindly click on the tile that corresponds to your answer. So is it community leverage mechanism? Is it community-led maintenance? Is it citizen-led monitoring? Or is it community-led monitoring? Key in your answers. Okay, so I think majority got it right. So CLM stands for community-led monitoring. So that will be our topic for this webinar. All right. So some of us did not get it right, but it's quite confusing because it's very similar to each other. The choices are very similar. Okay, so Pomelo is at the top spot, followed by Rihanna. Okay, let's move forward with the next question. So where was the Towards a Global Agenda for CLM meeting in August 22 conducted? So we're looking for the city and the country. Is it Geneva, Switzerland? Is it Bangkok, Thailand? Is it Addis Ababa, Ethiopia? Or is it Rio de Janeiro, Brazil? Key in your answers. Okay. Wow. A lot of you got it correctly. So it's Bangkok, Thailand, right? So you can search on it online so that you can get the full transcript of the proceedings of the meeting, right? Okay. Pomelo is still at the top, and then followed by BV and then Sky. All right, good. Next question, which of the following is mentioned as a core principle in the August 22 meeting? So we're still talking about the same meeting. So is it independent on CLM is independent as on donors and funders, led by professionals directly implementing, and CLM monitors are service users that are trained. Okay, so for this question, as I mentioned earlier, there can be more than one answers for a question. So most of you got the CLM monitors are service users that are trained, supported, and compensated. But it's also true that CLM is independent from donors and funders. So one of you answered actually that correctly. Okay, Pomelo is still on the lead. Next question. All except one are challenges in implementing CLM that were mentioned in the meeting. So what were the usual challenges? What were the challenges that were mentioned in them? Is it different stakeholders having different expectations of what CLM is, developing CLM models for malaria, funding for rigorous operational research? So the correct answer is having a shared global vision for CLM. CLM's long-term purpose is not one of the challenges. So it's actually seen as as an opportunity. So the rest of these are actually challenges. No? So it's quite a complicated question. So I would understand if some of you didn't get it right. Okay, Rihanna is catching up. Pomelo still on the lead. So next, what is the first step in implementing CLM? The first, is it establishing the budgetary work plan and collaboration foundations, the committee assessment of resources, or the committee members analyzing current services, or the development of a robust data and information. All right, so a lot of you got it correctly. First, we have to do a committee assessment of the resources, context, and the current implementation of CLM. Okay, next. Okay, BV catching up, and Len. Next question. CLM has been implemented in the following health conditions. Is it HIV, tuberculosis, mental health, diabetes? So you can select more than one for this question. Okay, so the correct answer is everything. So CLM has been implemented in all of these, no? So HIV, TB, and even malaria are the more popular ones. But I think Pakistan was also able to implement it for diabetes as well as mental health. So it's interesting that CLM can be applied in different health conditions. And now we will be talking about how to integrate it in PPR. Next. The following are reasons for the use of CLM except so you can have more than one answer to this question. Okay. But the correct answer is advanced integrated health system centered approaches. All right? Because it should be community centered approaches, not health systems centered approaches. Okay? True or false? Countries and regions may include CLM in all funding requests to the Global Fund. Is it true or false? And we'll just cut this to 10 seconds because it's quite easy. I will keep it. So okay, so yes, you can actually include CLM in funding request to the Global Fund, right? Okay, Andy, taking the lead now. Another true or false question, CLM can be implemented directly by government service providers by themselves to monitor the quality of their services. True or false? Okay, false, right? So this is actually one of the traditional ways of doing monitoring, but CLM is actually it should be community led mainly, no? But there are options to do it with the government, but it's going to be a CLM coalition type. So there's a different setup for that. But mainly CLM is implemented by the community. Okay, true or false? CLM data must always be integrated with the data collected by the national government. So CLM data must always send national government. Okay, false. The answer is false. Because sometimes CLM data has sensitive information, and the owners of the data of CLM are the community. All right, so it's not required for CLM data to be collected by the national government. Okay, so we have Pomelo on the third place, Gemma O on the second place, And then for first place, we have Rihanna. Right? So maybe no, we have Len and Andy as runners-up as well. So congratulations to Pomelo, Gemma, and Rihanna. Please reveal yourselves in the chat if you're Pomelo, Gemma, or Rihanna, so that we can give you a kudos. We don't have prizes here. But thank you for joining this activity. So now let's proceed to our session. Okay, so just to give a rundown of the different resource materials that we have the website, the Copper Knowledge Hub, so you can visit it at copper.apcaso.org. And then you can also look at the post-webinar articles. So for every webinar, we have an article that you can read, just in case that you don't have time for to view the recorded materials. We also have the PPR guide for communities. And then we also have the PPR training module so that we can build the capacity of communities in human rights and advocacy work in PPR. So now let's proceed to our first person who will give the message. So we have Ms. Rain Cortez, who is currently the Senior Program Officer for the Copper Community-Led Monitoring, Community Responses, and System Strengthening Team. And she is also part of the Community Rights and Gender Department in the Global Fund. So over to you, Rain.
Thanks, RJ. Can everyone see the presentation, right?
Yeah, so we just need to full screen it.
Okay. Yeah. So good morning, everyone. So again, I'm Rain Cortez and I work with the Global Fund, Community Rights
Rain?
and Gender Department. I work closely with Olive Mumba, as you may have known, who leads on the community engagement for pandemic preparedness and response. And in my work, I closely collaborate with Olive because I also work in communities in pandemic preparedness. But this time it's in the context of community-led monitoring. And thanks, RJ, for that Kahoot that we were able to a good refresher, at least, on what community-led monitoring is. And as we know, and as defined by the Global Fund, that CLM is seen as an accountability mechanism, community-led and independent of other monitoring systems, but basically being used for monitoring services for HIV, TB, and malaria to make improvements and to advocate for the service improvement changes. And that's generally how we are defining community-led monitoring ever since it has been introduced years ago as a mechanism to be able to improve and make health outcomes better aligned with improving community and health systems as well.
Rain?
And yes,
Sorry to
sorry.
cut you off. I think the slide shared is currently not in full screen, so it's in presentation mode.
Oh, okay.
Yeah.
Sorry.
All right. Thank you, Rain.
Let
Sorry
me
to interrupt.
see. Sorry. It always goes to, let me see. Mhm. How is this one? Sorry.
Looks good.
Okay, great. Sorry about that. So just to probably give you an overview, because this is the first time we are presenting, at least for the Copper Lessons webinar, about Copper CLM, and being a complementary intervention or initiative together with the community engagement or Copper CE. This has been also been conceptualized way back during the COVID-19 pandemic, wherein we are trying to provide technical support to existing CLM mechanisms that is focused on HIV, TB, and malaria to be able to also respond to the impact of COVID-19 to HIV, TB, and malaria services. And as we know, we are already post COVID-19, and we still have these investments that we call COVID-19 response mechanism grants that is provided in many of the countries. We actually try to think beyond just COVID-19 and try to venture towards more broader pandemic preparedness work which of course is aligned with our efforts in resilient and sustainable systems for health. We did have a previous webinar conversation on RSSH and PPR led by our colleague David Lawrence a month ago. And you can see that RSSH and PPR goes along together, and it is very important for us in the Global Fund to not just strengthen HIV, TB, and malaria services, but as well to be able to um, strengthen community and health systems alongside the service provision that we are having. So here comes our intervention on community-led monitoring for pandemic preparedness. And this initiative that we have has been running since 2024, and it will actually end by the end of this year or by the last quarter of this year. But basically, if you look at the three objectives that we're trying to achieve, is that we want to make sure that we provide PPR literacy to CLM implementers, make them understand what are the different PPR priorities, and let them improve their CLM mechanism, make it adaptable or flexible to be able to include some key PPR priorities that is relevant to the country, that is relevant to their context as CLM implementer, and to integrate that in their existing mechanism. The second objective is all about trying to engage and establish a robust and better engagement of CLM implementers to other actors and players that are engaged in pandemic preparedness and response. We know that many of our HIV, TB, and malaria CLM implementers may not directly be engaging in PPR spaces, but for them to be able to leverage on CLM PPR data that they can gather and they can contribute or they can complement, they need to engage in those civil society organizations, or whether it's a government agency that is already leading or engaging in these PPR spaces. And the last objective is generally on evidence and learning. And as we know, some people might see, or some countries might see, the integration of PPR into CLM as a not as a concept to be piloted. We haven't seen clear examples yet of how CLM is going to contribute into PPR initiatives. So we want to make sure that we document as we provide this support to countries to integrate PPR into their CLM, is to be able to document that, provide key technical resources that can help them progress to that stage of integration of PPR into their CLM, and support as much possible the availability of scientific literature to be able to see how really CLM is important in providing health outcomes and impact into health systems and community systems. And that's what we wanted to achieve in this initiative through these three interventions. So predominantly, we are providing technical assistance, though it is more targeted to our priority countries of the Global Fund for RSSH. But at the same time, we are providing support for CLM partners to engage in PPR spaces in the countries if they are not yet engaging in this PPR-related meetings, working groups, or not engaging with their IHR focal points in the countries, for examples. We have the ability to help them support engagement in these spaces if they are not yet in there. And as mentioned already in the evidence learning, the development of tools, learning convenings, research grants to develop scientific literature are also interventions that we are doing in this initiative to be able to support that integration in a way to pilot them in several countries. I think an overarching framework when we were trying to conceptualize on how do we really make this PPR integration work and integrate them into CLM. And I think the very important core of that is to actually really scoping up what is currently available. For example, as a CLM implementer, you are already gathering data on CLM that is related to HIV, TB, and malaria. And what we need to keep is we need to keep that as core of their job as CLM implementers, and see how else can we review, for example, or look at your existing indicators and see how it can be improved that is more aligned to PPR. And that's, I think, that's the red sphere in here. That is what is important. But at the same time, you need to look at global, national priorities and gaps. What are you monitoring in your, and what are you reporting or monitoring in your NAPS, JAE, and SPAR, that you think as a CLM implementer, you can contribute for the country to achieve um, national targets or in their state party assessment and reports. But at the same time, looking at the overall international health regulations, which many of you are familiar with already, you also need to look at the different domains or technical areas of IHR or focus areas, if I may say, and you may look at which ones are relevant for you as a CLM implementer. It might be about at the stage of trying to prevent a pandemic or trying to support detection of pandemics, or even responding to when there is already a pandemic. How can you leverage on a CLM mechanism to be able to provide data that is relevant to prevention, detection, and response? And all of these three spheres are very important to take into consideration in what eventually, as a community, you decide on what to integrate into your CLM. And I think that remains to be the overall guiding principle that we are trying to follow in here. And in respect that we are trying to fit PPR into the existing CLM mechanism in this case for it to work and not the other way around, or not trying to develop a new or siloed CLM mechanism that is only just for PPR. That's why I think the word integration is very important, because we want to leverage on existing CLM mechanism and just to improve and expand it by trying to include selected PPR indicators into it and not create a totally new one in this case. So in this case, as you can see, if you are familiar with the CLM cycle, the one that with the different colors in here, I think our support is also aligned basically with the CLM cycle. And if you're trying to integrate PPR into CLM, that can also happen in any stages of the CLM cycle. As you can see in here, even up to the development or refining of your CLM national frameworks, trying to improve or revise or refine your CLM indicators, if you're trying to improve site selection or your data analysis space, if you want to improve your stakeholder engagement for advocacy spaces. Those are the similar cycles in a standard CLM that is also applicable to the PPR. And our initiative is supporting that in many countries to also be aligned in how we can improve or refine their CLM mechanisms to integrate PPR. The ones that are in bold in those cases, if I can mention, the development of CLM PPR indicators, the engagement, the mapping of CLM PPR spaces, and identifying actors in the field to be able to engage them for data advocacy. And the third one on PPR budget analysis and tracking using CLM. These are all aligned with the CLM cycle. And these are the three areas that we are looking at to provide support and providing a complementary technical resource, or what we call a community guide, that we are presenting in this webinar. We want to make sure that as countries traverse into improving their CLM mechanisms to integrate PPR, that we are also to provide quality community guide, easy to read resources. And for this webinar, we are going to be presenting two of them, which is on the CLM PPR indicator development, and the one on CLM PPR advocacy toolkit being developed by two of our consortiums. And later on, we also have some country sharing experience from Kenya and Malawi, who have recently completed your technical assistance to share their experience on how they were able to thought process the integration of PPR into CLM and share their experience on what they think are PPR priorities that can be integrated in their work. Before I just end this mini orientation and overview, if I may say, just to recognize our CLMTA provider consortiums that are leading on this work together with the CLM partners on the ground, led by ITPC, who is leading the Metal Consortium, together with Matahari and other partners, and also the INASO-led consortium, as you can see in here, and the CLOC consortium that is held by Odelpha. So we will hear from two of our consortiums on the resources that they're developing. Just to mind you that these resources are still ongoing development, and but we want to give you a snippet of what we to expect in these resources that hopefully will be helpful to country partners in terms of their PPR integration into this. I think that's all from my end. So I hope I were able to provide an orientation on copper CLM and at least what we are doing and what goes to behind our minds when we were trying to conceptualize on this. And we are hopeful that the two resources that we are presenting will be useful to you, and as well the sharing of our two country partners in this case. Back to you, RJ.
Thank you, Rain. That was a very good introduction to the different committee guides that we will discuss today. No, and I think it's important to get from Rain's presentation earlier that when we talk about the integration of CLM, the integration of PPR in CLM, it's quite new, but it's very familiar also because it's also the similar process if we do it for other disease conditions. So now I'd like to forward the conversation to our main discussants for this session. So we'll have two speakers who will talk about two community guides. So the first one is a guide for developing high impact CLM PPR indicators for advocacy. So it will be delivered by the CLO Consortium, and the speaker will be Alice Cayongo. So Alice Cayongo is a public health practitioner and human rights advocate with 17 years development experience working largely with civil society, where she has held several positions. So she is currently working as a senior associate with the O'Neill Institute for National and Global Health Law at the Georgetown University Law Center. She is also an active researcher within women's and children's health rights sector in Uganda, Africa, and internationally. She holds a bachelor's degree in sociology, as well as Masters of Public Health. She is also a 2021 Harvard Lead Fellow and the member of the Developing Country NGO delegation of the Global Fund and volunteers on several boards, including the Health GAP board, among others. So I'd like to turn over the floor to Alice Cayongo, and then later on we will proceed with the sharing of FIFA Raman. Over to you, Alice.
Thank you so much, RJ. And so the one thing that we have learned to do virtually is say good morning, good afternoon, and good evening to everyone, depending on where you are. And for those of us who are not sure about our location, I think I will just say hello to you all and very happy to see you here. A couple of you that I know as participants, as well as colleagues that we do work with. As mentioned, I am representing the CLO Consortium, community-led, excuse me, the Community-Led Accountability Working Group, working in partnership with Waki Health and Coalition Plus, who have gotten together to put this resource tool together. Next slide, please. So this resource tool, as indicated, is in a draft form. And the title is actually a practical guide for developing community-led monitoring indicators for pandemic preparedness response. And the overall goal is basically to strengthen national and subnational preparedness for future pandemics and current pandemics. But we also have a purpose. The main purpose for us is basically to guide CLM implementers through the process of identifying PPR indicators and basically revising and integrating them into the existing CLM projects. I can't even explain this enough because Rain has already, thrown a lot of light and emphasized this process. As mentioned, this tool is being developed by the CLO Consortium in partnership with Waki Health and Coalition Plus. Next slide, please. So what is this resource for? First, it is a guide that is basically leading us through a process of identifying indicators. It ensures that there is alignment with the international health regulations as well as the joint external evaluations. It also emphasizes community engagement. It provides a step-by-step guide for creating an effective survey questionnaire. It provides case studies, including real-world case studies of CLM programs that have adopted PPR. And then finally, it focuses on a practical implementation with emphasis on advocacy impact. We know that for sure in all that we do under CLM, we actually do want to advocate for a change in systems, a change in practice, but a change in policy as well. Next slide, please. And so this tool is targeted mainly overall. This tool is primarily targeting community actors as well as community-led organizations or community organizations that are implementing CLM programs. However, we are also targeting other CSO networks that may not necessarily be conducting CLM, but are involved in PPPR and health security. We are targeting the affected populations, affected by HTM, but also affected by any outbreaks, pandemics, epidemics. We are targeting health service-related CSOs, especially those that are currently providing HTM, but also those that may not necessarily be providing HTM, but are, providing other health services, including, for example, immunization and several others. So those we are actually targeting. We are emphasizing PPR-focused advocacy in that there may be organizations that are not any of those that I have mentioned, but are actually only doing advocacy for PPR. So we are targeting those organizations as well to be able to utilize this resource. And why we are targeting mainly the community actors and community stakeholders is basically to ensure that there is, first of all, community ownership, that there is also community leadership in monitoring, but at the same time, we are doing this to ensure that there is independence in CLM for PPR, is independence from any of the institutions that we will be monitoring. And that is why we are targeting mainly community actors. However, this is not to say that we do not work with other actors, including the government and donors. We do work with other actors. We collaborate with them. As you know, our advocacy would never be effective if we do not collaborate with others. But the emphasis is mainly on the community actors, the community stakeholders, who then would be interacting with the other actors, including the government and donors. So for the government and donors, they can actually provide advice. They can provide any form of guidance. It's eyes on, but hands off for sure. They cannot be part of the decision-making in the processes that are being conducted by the community actors at community level. Next slide, please. So the thought process that, first of all, how we are developing high impact indicators, it's a 6-step cycle that we are looking at. And first of all, the first indicator is convening community experts and advocates to ensuring that there is diverse representation. There are many of the current CLM programs do have such groups. So where there are such groups, it is okay. We can still carry on with these groups, and then we move on to the next step, which is educating them on the PPR concepts, frameworks, including the IHR, the JEEs, the NAVs, and the SPA. However, for those programs that do not have these groups, the community experts, we do expect that for CLM for PPPR, we are convening such a group of experts. And once we have convened them, we are educating them, we are sensitizing them, and basically strengthening their capacity in the concepts and the frameworks related to PPPR, not forgetting the international health regulations, the joint external evaluations, the national action plans for health security, and the self-assessment tools by the government. We also need to define community health needs as well as the advocacy priorities. This, again, is pretty much in line with the CLM cycle that Rain just presented. Because once we have educated the experts, we need to define the specific community health needs with regard to PPPR, and then also define what the advocacy priorities are. We then have to map the evidence needed for advocacy. What kind of data are we looking at? And that's where we get into the kind of indicators that we are actually, the specific indicators that we are referring to. But as we map out the evidence as well, we also need to map out what is existing on the ground, who are the actors on the ground, who are those doing PPR, who are those doing CLM, who are those, who are the different actors that we need to map out so that we can work together in collaboration as we do identify the specific the specific evidence that is needed to inform our advocacy. And once we have the evidence, we then develop a questionnaire based on the evidence that we have, based on the mapping that we have done. The mapping of the community needs, the mapping of the advocacy that is needed will then inform a questionnaire that we want to be able to use as we are collecting data. And once we have the questionnaire in place, then we will be able to, we should be able to pilot this questionnaire in order to create effective surveys. So we are looking at this step this process as a 6-step cycle that includes all that I have mentioned. Next slide, please. So in terms of the content, what are we going to monitor? The resource clearly indicates the different, that there are several issues, focus areas, or capacities that the international health regulations does provide. Out of the 19 capacities that are provided for by the international health regulations, we feel that there are 8 of them that would be most relevant to CLM. However, these are not they are not exhaustive. They can be adjusted to include the others, but for now, we think that 8 out of the 19 are what may be directly applicable in this case. One of them being laboratory surveillance, and some of the indicators there would be the availability of diagnostics. The other would be infection prevention control. One of the indicators there would be the presence of hand washing facilities. The third would be health service provision, and the indicator there would be reports on continuity of essential care. The fourth is on immunization, and the indicator there would be on required vaccines, also provided in the right quantities, but also equitably distributed in different parts of the country. The fifth is on risk communication and community engagement, which basically covers indicators on knowledge, basically knowledge around prevention, knowledge around treatment, but also knowledge around care. The sixth is on points of entry, where we are looking at presence. One of the indicators there would be the presence of temperature screening, also even presence of, adequate staff at the points of entry, but also adequate staff who are well trained to actually take temperatures and make the readings. I know that in some places we have seen security guards who are taking temperature. We don't know whether the temperature is accurately measured, whether it's accurately recorded, but yes, you and I know that we have seen security guards in some points of entry being responsible for such roles. The seventh area, focus area, is on the health workforce capacity. And one of the indicators that we are looking at here would be availability and accessibility during emergencies. When we go to a facility during an emergency, in my own country, Uganda, there is an outbreak of Mpox. So if anyone goes to a facility in Uganda, do they actually see enough staff who are, providing services for Mpox? The last eighth is on supply chain management, and here one of the indicators is on reports on barriers to essential supplies. Are there essential supplies provided? If so, if not, why aren't they there, and things like that. So these are the 8 areas that we are actually focusing on in this resource tool. 8 areas out of the 18 focus areas that are provided for in the international health regulations. But then the one thing that we note is that while we are focusing on these areas, we are making sure in the resource that these areas are actually informing, the indicators are informed by the focus areas of the international health regulations. They are informed by the outcomes of the joint external evaluations. They are also informed by the national action plans for health security, as well as the SPA in the different countries. And the selection of these is actually based on the community priorities as indicated, and ensuring alignment with the national action plans on health security, and where CLM should be complementing the monitoring systems. Next slide, please. So out of the 8 focus areas, I did pick out just only 4 to let you know what is the difference between what is being monitored at community level and that is being monitored at facility level, for example. And of course, remember that our tools, survey tools will include, we will have the qualitative work, but to one extent, we will also have quantitatively, especially when it comes to facility level. But at community, as community-led monitors, the biggest area comes in with qualitative, but for sure, we do monitor at facility level as well, and that's where a lot of the quantitative data comes in. So the first is with infection prevention control, and at community level, we are saying we are, looking out for the specific public spaces that do not have functional hand washing stations. And why don't they have? When I go to a market in Kibera in Kenya, why don't I see a hand washing station? But then at facility level, I will look out for the percentage of health facilities with adequate hand washing stations that have soap and water. The second area that I am looking at, just randomly as an example of what is provided for in the resource, is on the risk communication and community engagement. And here at community level, we are looking out for how and what PPR information is received at community level. But then on the other side, at facility level, we are looking out for the percentage of facilities that are displaying health information in local languages. At the points of entry, we are looking out for communication. Are the communities receiving information about the health requirements and screening procedures? But then when we get to the facility level, we are asking about the percentage of the designated points of entry that have functional screening protocols. When I get to immunization, at community level, for example, we are looking at the difficulties faced when accessing immunization services during an outbreak. But then on the other hand, at facility level, we are looking out for the percentage of health facilities that are reporting required vaccines that are required and whether they are being reported to be adequate enough. So these are some of the examples that I wanted to, that I pulled out to share with you what can be monitored for CLM PPPR at facility level and at community level, bearing in mind that at facility level, it would be quite much more focused on the quantitative part, but then at community level, we would focus much more on the qualitative part, looking at the why to an extent. Next slide, please. And I just want to share very quickly one case study in South Africa during the COVID pandemic, where partner organization Richitse did they did integrate, CLM, PPPR into their CLM program. And the background was that the team adopted COVID-19. They adapted to COVID-19 and continued to monitor health services, including access to quality COVID-19 services. And their approach basically involved developing SNAP surveys administered remotely during the lockdown. It also included monitoring the disruptions of HIV/TB services, and it also included tracking access to PPPE as well as COVID-19 vaccines. And they did actually accomplish certain milestones or achievements, one of them being that they secured multi-month dispensing for HIV/TB medicines. They also obtained permission for monitors to travel during the lockdown. You remember many of us were not traveling during the lockdown, but Richitse successfully got permission for their monitors to travel during the lockdown. And they were also looked as a trusted member in the community that was providing information on COVID-19. And so that can actually be a lesson for them and for us all moving forward with any other outbreak. In countries where, Ebola is being reported, cholera, Mpox, and others, we can apply some of these to our own settings, integrating them within our ongoing CLM programs. Next slide, please. And how to practically use this tool. First of all, I do recognize that this is basically involving integration of services of PPPR in the ongoing CLM for HIV/TB and malaria. However, there are some organizations that may come on board that have not been doing CLM in the past, CLM for HTM in the past, but they want to do, they are able to do CLM for PPPR. And so what we are saying is that these organizations will basically need to follow these 6 steps, the 6 steps that I have presented religiously. But then there are those organizations or programs that have already been ongoing, and those programs will basically revisit the advocacy priorities to ensure that in addition to the HTM advocacy priorities, we also have priorities for PPPR. And that will mean that they will refer to relevant sections that they need to revise in order to indicate, to have indicators for PPPR. They have to be able to test if these respective questions are going to give us high impact data, and basically to pilot and refine these questions again to make sure that we are obtaining information, the information that we need. And the key principles to note overall are the principles that we have been following for CLM since time immemorial, one of them being community ownership, independence, inclusivity, as well as focus on actionable data that connects to advocacy priorities. And very, very importantly, we need to know that CLM for PPPR is contextual. It's not as one size fits all. You could find that points of entry in one community, one country are okay, and possibly we don't need to do very much there, whereas in another country we need to do a lot with regard to points of entry. So it is highly contextual. It depends on what the community needs are and what the advocacy priorities are. That is what will define what the CLM for PPPR program will look like. Next slide, please. So in a nutshell, I just want to summarize what I have said. 6 steps involved in the development of indicators for PPPR, one of them being convening, the second being strengthening capacity, the third being defining the public health need as well as the advocacy priorities, Fourth is mapping the evidence needed for advocacy, but also mapping the current actors, what exactly is existing on the ground. The third is developing questions. And lastly, we are piloting the questions. Next slide, please. This is my last slide, basically to acknowledge all members, participants, first of all, starting with the CLO consortium that I am representing here, working in partnership with Waki Health and Coalition Plus, but also acknowledging our partners who are the conveners of this webinar, being led by APCASO. And of course, it would be extremely unfair for me not to mention the financial support that has come in adequately from Global Fund. Thank you very much. And as mentioned, this is a draft for which we will be happy to receive feedback from you all.
Thank you, Alice, for that very clear as well as very succinct presentation. I think it's a helpful guide as our different countries identify the different PPR indicators. And I think I particularly like your how you identified the indicators that are applicable in the community and at the facility level. And I also like the point that you emphasized that qualitative measures or qualitative inputs are also very important. All right. So thank you, Alice, for that. So now let's move on to the next presenter. So we will be talking about the mapping entry points for PPR advocacy and how community-led organizations can use CLM to inform PPR processes and advocacy. So our speaker for this part of the webinar is FIFA Rahman. So she is the principal consultant at Matahari Global Solutions, a consultancy firm focused on global health solutions with local relevance. She is a specialist, a global health lawyer with a PhD in political economy and trade-related intellectual property for biologic medicines. At Matahari, she leads a multinational team of 8 working across multiple key projects, including on developing the African Union Health Workforce Compact, on gender in public health emergencies, decolonial grant making, and critical path analysis for novel diagnostics, including those for chlamydia, gonorrhea, and TB. She was also the pandemic negotiations consultant for the Africa Group negotiators on the pandemic treaty negotiations from January to August 2024. So now I'll turn over the floor to FIFA Rahman. Over to you, FIFA.
Thanks very much for that introduction. So today I'm going to be providing a little 10-minute brief overview of the toolkit, and we're part of the COPPA group for advocacy leadership in CLM and PPR. I noted the comments in the comment section on the need for French slides, so I was trying to include French, but unfortunately the front slide wouldn't change, so I hope you'll forgive me for that. So moving to the next slide. So this is a little bit of an overview of what we're covering today. This is by no means the complete picture of what's in the toolkit, but what we're going through today is a little bit about the advocacy toolkit objectives, what is in the international health regulations and what does it mean for communities, who is involved in PPR, and what can CLM track. And this is just a snapshot of what we'll include in the toolkit. So let's go into the objectives and content of the advocacy toolkit. Ideally, what we want the toolkit to achieve and what it should contain is a description of who are the main stakeholders in pandemic preparedness and response. What are examples from COVID-19 and what does that teach us for community-led monitoring in the next pandemic? What parts of the international health regulations are of main interest for HIV, TB, and malaria, and CLM in PPR, and important PPR documents, processes, and terminology to understand. And hopefully this will equip communities to understand who to target with their CLM data. In terms of methodology, we interviewed 16 key informants. I do believe that's increasing to 18 or 20 in these coming weeks, with different exposure and participation in PPR across the world. So it included some Global Fund staff. We also spoke to a One Health expert in India. We spoke to community representatives, and we spoke to different experts who work across the PPR world, essentially. We had 2 key informants respond in writing. And basically, we use a semi-structured questionnaire to do these interviews. And we've triangulated the data from the interviews with existing resources, as well as our own in-house expertise and additional desk research. This is the table of contents. So apologies to the Francophone colleagues. I wasn't able to translate this because it was a snapshot of the table of contents. But we started with acknowledgements. We have a table of figures, our methodology, then what went wrong in the COVID pandemic and what can we do better? So for example, in the COVID-19 pandemic, in Kenya, for example, there were arrests of community health workers for not wearing masks, and that obviously compromises the pandemic response. So we've got little descriptors of what went wrong in the COVID pandemic in really brief sentences, and what can we do better and what should happen. We've also got a section on who is involved in PPR, and we've mapped this according to local, national, regional, and global levels. We have a section on what are the international health regulations and why they are relevant for communities. And what we do in that section is present the verbatim text of what's in the IHR, but also digest it as to why it's relevant to communities and what advocacy messages can come out of that. And I'll provide a couple of examples in the next slide, as well as what CLM can track in PPR. And this is where it kind of overlaps a tiny bit with the previous presenters toolkit, but not too much. We cover it quite briefly, and the previous toolkit covers it in more depth. And then we provide some CLM best practices on PPR with 3 case studies. And then we include some tools for CLM advocacy, and that includes some social media assets that communities can just modify and put online, as well as an advocacy log. So that is what we are including in this toolkit. So this is a little snapshot of one section in the toolkit. That is what is in the IHR and what does it mean for communities. So this section is structured in a table format, and we've categorized it on the left in terms of subject area of the IHR obligation in brief, with the verbatim text just in case it wants to be referred to. What this means for communities and an advocacy message. So I'm not going to read the whole thing, but I'm going to provide a couple of examples here. So in the first example, the subject area is the obligation of states to develop and maintain core PPR capacities. So in the IHR, you have an annex that has all the core capacities that countries need to adhere to. And the verbatim text basically says that state parties should assess that and should maintain the core capacities. So what this means for communities is that the state must have a process and plan for developing those core capacities related to public health emergencies. And if the state doesn't have that plan, that is something that the communities can take. Sorry, there's somebody speaking. Can you please mute? So yeah, essentially that's what it means for communities, that the communities can hold the state accountable because that is what is contained in the IHR. So the advocacy messages could be, and there's one positively framed one there and one negatively framed one there. The advocacy message here is that the state must use CLM to assess core capacities at the local and national level. And an example could be, one core capacity is that laboratories work well, testing works well, and CLM can track that, okay, laboratories are not working, testing is not working in a pandemic, and the state must listen to that and use that data to assess and improve the core capacities at the local and national level. And then there's an advocacy message there, which is more negative, that the state is contravening international obligations by not developing, for example, laboratory expertise. So we provided one example there, but there are other examples of core capacities in the IHR that the state should adhere to. The second example is on participatory approaches in risk communications on pandemics. So, for example, during the pandemic, some of the risk communication was communicated in English rather than local languages. And that compromises pandemic preparedness and response, because if communities are not receiving the information in their own languages, how are they going to protect themselves and their families? So the verbatim text from the JEE, this is from the Joint External Evaluation, says that the risk communications approaches should follow a whole of government approach, and that appointed spokesperson should be trained in risk communications. And we saw this during the pandemic, where some appointed spokesperson were not empathetic to communities, and that shows essentially that they weren't trained very well, right? So what this means for communities is that communications about pandemic risks must be evidence-based, tailored to the communities they are targeting. They have to be in the local language that is understood. And the fact is that this can only be done through a diverse consultation group, and with a spokesperson who is trained in risk communications, and that they have to understand the risks, so they must know how to translate the technicality to something that will be understood by communities, and they need to speak clearly and with empathy and understand what the communities are going through. So this is an obligation of what it means to communities, and the advocacy message can be that the comms, the materials that go out that communicate the risks, must be by the most used or convenient medium. So if people in that village mainly use radio, the risk communication should occur through radio, and that the development of risk communication materials must meaningfully involve all relevant partners. So if the government is creating these comms materials for TV, for radio, for whatever means, and they're not consulting community groups, and they don't understand what community groups need to understand, that's a problem, and that's something that CLM can use to monitor and to report. So the next slide, and this is another section in the toolkit, is who is involved in PPR. So essentially, what we want is for communities to read our toolkit and know who to target. So the local level is probably most important for CLM. So what we've done there is plotted a number of key stakeholders, and we're happy to expand it as well, but this was developed based on our interviews. So we've got clinic managers, facility management teams, community or traditional leadership, provincial directorates, civil society organizations, social networks, social services networks, and community health workers. And what we're doing in the toolkit also is to expand on the roles of each of these stakeholders at the local level. So, for example, traditional leaders have a deep connection with local communities and are especially important in pandemic preparedness and response because they are trusted figures in their communities, making them effective at disseminating information about health crises and enforcing control measures. We included an example from Malawi where traditional leaders mandated mask wearing, restricted large gathering, and established hand washing stations. And we include how you as communities can use your CLM findings, and advocate with traditional leaders because they act as intermediaries between governments and local populations. And that allows these leaders to advocate for necessary changes based on your CLM data. So essentially what we'll do in the toolkit is define how you can use your data with each of these different stakeholders at the local level. And of course, you can also use your CLM data at the national level. And we've included one example with the One Health coordination platforms. And with One Health, it's all about preventing zoonotic spillover. So when animals have a kind of disease that can be transferred to humans. So if suddenly you're monitoring in your communities that there's unexplained animal deaths like a whole bunch of chickens have suddenly died, then this platform will need to know. And this platform is usually a combination of the Ministry of Health. So somebody's drawing on my slides. So if people can mute, but also not draw on my slides, that would be great. But yeah, so we've got this One Health platform, which is a combo of the Ministry of Health, usually the Ministry of Wildlife, the Ministry of Agriculture, and others, which you can target with your CLM data. And CLM is usually used at the local and national level, but in case there is advocacy space to use your CLM data for more global things, we've provided global examples as well, such as the World Health Organization, UNICEF, World Bank. And we've provided an example of what UNICEF did in the COVID-19 pandemic. And of course, there are regional actors as well, such as SADC, ECOWAS, others, Africa CDC, and regional development banks. And the banks did a lot during the COVID-19 pandemic as well. But of course, I've been asked to emphasize that your data will be most useful to be used at the local and national levels. So Adi, do you mind not maybe not clicking annotate, because I think it's you that's drawing on the slides. Thanks. Okay, so what can CLM track is another section in the report. And this is a diagram that's in the toolkit, and it looks a bit small, but what I'm going to do is I'm going to expand some of these bits. But essentially, there's all sorts of things that CLM can track in PPR, including in risk communications, community engagement, financial preparedness for pandemics, gender in pandemics. And gender, we did a full report on gender in pandemics, and it showed that housewives, homemakers in particular, didn't have the same access as others because they had market responsibilities, child rearing responsibilities, and couldn't necessarily travel to access tests and vaccines. So there's things that can be monitored in gender, human rights violations, One Health, and access to routine health services. And this can include things like during a pandemic or waiting times at clinics longer during the pandemic. So here we're going to look at access to routine health services more closely. And I know that my colleague who previously presented is doing this in more detail, but here are just some examples of what can be tracked in routine health services and how it's linked to the IHR or the JE. The example below is is there a defined package of essential health services, and are these evaluated and updated based on lessons from real world events? So if there isn't a package of essential health services, or there is a defined package of essential health services and communities are not getting access to them, that is a problem that CLM data can track. And CLM data can also track whether anyone has been turned away from clinics without their TB or HIV medication. And I should say malaria as well for that. And in risk communication, there are a number of things that CLM data can track, including what is the acceptability, availability, accessibility, and quality of risk communications messaging. So if the quality of the risk communications messaging is poor, such as wash your hands, but no one knows for how long, nobody knows how frequent, and it's not available in the local language, that is a problem for accessibility as well. Was risk communications messaging available in all local languages? And as described earlier, does the risk communications approaches utilize a whole of government approach? And this is something that is quite relevant. We've also got gender. I've described a little bit on gender, and I've written there the sort of sources where you can get gender-related gender-related pandemic indicators. Are there social protection measures available for women and gender minorities? Do local authorities have established pandemic plans around GBV shelters? And of course, we know that gender-based violence increased during the COVID-19 pandemic. And are services reaching women and gender minorities where they are or close to in the daytime? And this is important because if you have a vaccination center, but it's very, very far away from communities, what efforts are being done to bring it close to communities? So that's a very quick overview of our work. So I'd like to thank you from the team, and of course, happy to receive any feedback on our work.
Thank you, FIFA, for walking us through the community guide. I think it's really helpful if the different civil society organizations can identify who will be the targets of their advocacy from the local level to the international level. And also, thank you for showing us on how different areas can be tracked using your community guide. So again, let's give a round of applause to FIFA for her presentation. So now let's proceed to the next part of our session, which will be focused on the country sharing of our country implementer. So we invited Christine Mamsidu, who is the Community System Strengthening Advisor from AMREF Health Africa in Kenya, as well as Lawrence Konyongwa, the Executive Director of the Malawi Network for People Living with AIDS. So I'd like to call first Christine to share her insights on how they implemented CLM and PPR in their country. Over to you, Christine. There you go.
Hi, everyone. You can see me? You can hear me?
Yeah, I think it's clear. Please go ahead.
Okay, so I'll give an overview of how we've been able to integrate PPR or into CLM. So just to give an overview, so in Kenya, we have CLM projects being funded by various entities. So we have the one that is being funded under Global Fund. We had the ones that were being funded under PEPFAR, and then there is one being funded through Positive Vibes. And we also have a Stop TB doing CLM interventions in Kenya as well. So generally, we were able to update our CLM framework recently. It is in the process of being completed. We're remaining with the validation and launching process, and then the framework will be complete. But generally, so it has various thematic areas, that is HIV, TB, malaria, social support, infrastructure, human resources for health, human rights, and now the PPR components that we are bringing on board. So basically, more or less some of those areas like infrastructure, HRH can also touch on things to do with pandemic preparedness. So through the COPA CLM intervention, we were able to, and also in collaboration with the COPA CE side of it that is being done by Stop TB, we were able to come up with the training materials for PPR, and the communities were oriented on the PPR. We were able to do the first training of people who now will support with the cascading of other trainings that we are supposed to be implementing soon. And through that same meeting, we were able to identify key priorities for PPR and also indicators as per the JEE areas. So we also had an activity towards reviewing and updating of our CLM advocacy plan. So each partner had their own plan. So we were able to come together and develop one common CLM advocacy plan. And this will also form part of our CLM framework to ensure that communities have this key document to move advocacy. And also there was a plan that will support with the engagement of stakeholders with regards to PPR. Then on the review of our CLM tools so that we are able to introduce PPR. This was also done, and currently we have a pillar. We introduced a pillar 4 on PPR, and then also under the CE part of the intervention, there is a scorecard that was developed that we are going to also adopt. And then the CLM, the indicators that were developed are also going to be able to inform the tools that we already have and add issues to do with PPR. So with that, with all this, we are using this now to cascade the trainings that are planning to begin in May. The reason why we are doing them now is because we are in the process of mapping key networks within the country. So then we can build these networks through many things, including them being able to take lead on CLM and matters to do with PPR. We also are able to bring on board a member from Ministry of Health, National Public Health Institute to the Community System Strengthening TWG. So then we are working together in this process. So lessons learned, we've been able to collaborate with the COPA CE, and this collaboration has worked well in terms of us coming together with what we have under Global Fund and what they also have, and being able to reach as many communities as possible, like I have mentioned. And then also the bit of understanding that even this was shared by communities as being able to just realize that CLM is a key powerful tool that can be leveraged to advance PPR. And then also community engagement is still suboptimal in Kenya. When the JEE was being developed, the CSOs were there, but in terms of communities, even the CSOs, they were not, the engagement was not as expected. So we are working with NPHI to improve this. And then with regards to challenges, we realized that we are still a bit behind with regards to understanding of PPR, and the toolkits that have been shared here today will go a long way with that, with regards to CSO space and communities. So we have the planned trainings that we are collaborating together with COPA CE to conduct and be able to increase this knowledge. So these activities were planned under the C19RM grant. Then under challenges, so through the because of the stop to work orders, so some of the CLM strategies in Kenya were stopped. So now we have minimal strategies, but we'll still use the available strategies to be able, the available partners who are implementing to continue with this agenda. So we had started together, but they are still in the space, and yeah, we are going to continue to working together to advance the agenda. So some of the areas that we are realizing, I don't want to call it a challenge, but rather an opportunity is, so everything we are doing under CLM and now bringing on board PPR is key, and there's need for a proper documentation of that area. So that's an area that is a bit weak in Kenya, and maybe for the next support, this is a key area that we would wish as a country to have supported. So in the sense that we are able to document our outcomes and our impact. Being the CLM being very qualitative, then there are those challenges with documentation of that and being able to attribute changes, key changes, say in M&E data to what is being done through CLM. So that is a key opportunity for support, and there's need for further collaboration. Thank you very much.
Thank you, Christine, for your sharing. No, so I think it's very clear that there are a lot of opportunities, especially if we maximize the platform for community engagement, as well as thank you also for sharing how you adapted to the different challenges. No, like for example, the stop work order that you mentioned, and also highlighting the importance of documenting, making sure that we also utilize our experience to implement better the next time. All right. So thank you, and Christine, for that sharing. So now let's proceed to the sharing of Lawrence Konyong from the Malawi Network of People Living with HIV and AIDS.
Thank you very
Lawrence?
much. Thank you very much, RJ, for giving me the time. I will continue from where Christine left. The Malawi CLM program is implemented by several organizations. I'll mention some of them. We have the Network of Journalists Living with HIV. We have Manaso, Manerela, ActionAid. ActionAid has a consortium of 3 organizations that include Manage Plus, Lilongwe Catholic Health Commission, and CRECOM. So the programs are now introducing the aspect of PPR. So we had corporate technical assistance, where we had a very, very robust training program for 3 days. So all the partners that are implementing CLM, we met by the lakeside to go into detail on PPR. And some of the issues that we covered during the 3 days included the joint external evaluation, JEE, as has been mentioned by previous speakers. We also looked at the international health regulations, state parties self-assessment, the SPA toolkit, and we also looked at various official guidelines and policies related to health and PPR in particular, looking at how our Malawi government has also addressed issues of pandemic preparedness and response. So these documents allowed the participants to gain an understanding of the building blocks in PPR, as well as how PPR-related indicators can be built into the current CLM framework. It was also noted that some CLM indicators speak to PPR, and these just need to be strengthened in order for them to align to JEE and SPA indicators. Let me also mention that we were able to develop major indicators for PPR that will help us to integrate into the current CLM. And we were able to draft the monitoring indicators, which mainly were in the following areas: health financing, where we're looking at PPR-related budget lines from the various ministries, departments, and agencies. Do they include PPR in their budgets? And then we also looked at indicators that can track the utilization of the funds themselves on PPR and the amount of PPR-related funds that have been dispersed to community structures. We also want to track that in our indicators. We also looked at the laboratory capacity, number of trained and qualified laboratory scientists or technicians employed, as well as other indicators. And we also looked at antimicrobial resistance as one of the critical issues that should be monitored, as well as the points of entry number of travelers entering the country through air, land, and water bodies, number of health staff deployed at every point of entry against the optimal numbers. So you'll see that it was a very good eye opener. We have started to incorporate PPR indicators into our CLM implementation. I'll just give you some of the examples that have been very, very practical. For instance, we are looking at the district response teams. The ministry has already put up response teams at national level, at district level, at health center level, and at community level. However, we noted that these rapid response teams are not functioning properly, and that is also one of the areas that we'll be monitoring. We are also looking at issues of the border areas. For instance, recently in one of the districts, the community itself was able to participate and alert the district communities on cholera and measles outbreak. This was after they had been trained. We also introduced a communication strategy where we had radio programs generally on cholera, mpox awareness, and other issues. So, as the previous speakers said, the community is very important. Once it is enlightened and once they have the knowledge, they are able to respond. I think that can be the end of my presentation at the moment. Thank you, and over.
Thank you, Lawrence, for sharing your experience in Malawi. I'd just like to highlight the indicators that you mentioned that you integrated in your as indicator. So you had indicators for health financing, for fund utilization, for laboratory capacity, AMR, as well as the point of entry. So probably we can also learn from their experience. All right, so now for the next part of our session, I'd like to call in again Alice, FIFA, and Christine to join us in the Zoom platform so that we can have the Q&A. So some of you already answered some of the questions on the chat. So thank you for the speakers who are very proactive in terms of answering the questions. So if you have questions, please do raise your hand. So utilize the raise hand function, or you can also chat your questions here. Anyone who would like to ask questions to our speakers and country implementers? Anyone? I think people are still warming up to the Q&A. But maybe we can answer one of the questions here live, because I think it's also interesting. So there's this question addressed to FIFA earlier from Tankiso Pori. So she was they were saying here that I think the role of private health facilities should be recognized. During COVID-19, there was a gap between private facilities and governments in most countries, including Lesotho. So maybe you can also add more inputs on this, FIFA.
Thanks, RJ. So, yes, we didn't include private facilities. It didn't come up during interviews, but now it came up in the chat. We'll definitely include them. And we know that a lot of people rely on private health facilities for the healthcare. So if that's interrupted or compromised in any way because of the pandemic, then those facilities should know and should improve their services. So we'll certainly include that in the toolkit going forward.
Thank you, FIFA. Any questions from our audience? Okay, so Jonathan, has a question.
Just a quick question
Yeah.
about what seen in
Hello.
Kenya.
Okay, I'll mute
Hel-
Pamela first. So we'll go to Jonathan and then we'll proceed to Pamela.
Yeah. Thank you very much. This is Jonathan Petekwao on the call from Ghana, and I'm the technical coordinator for HTM CLM in Ghana. I wanted to know whether the implementation so far on the PPR CLM, whether they took into consideration the animal health facility like the veterinary clinic. Do they took, because we know that in terms of animal health, they are the first one of the I would say the area or target area that brings about some of these pandemics. Where do they included the animal health and the veterinary as one of the entry points for the monitoring? Do they include it? And if they have, how? Thank you, and over.
Thank you, Jonathan. I think it's an interesting question. So if you're also interested about One Health, we have another recording for lessons on that. But any thoughts on that, FIFA or Alice?
So we have included One Health. We did interview a One Health expert and included some insights in the toolkit, but mainly on unexplained animal deaths. So if there are unexplained animal deaths, you would want to track that in the communities and report that to the government. I don't know to what degree veterinary clinics would log that and report it, but it might be a useful stakeholder to include. What I'll do is I'll note this and then I'll ask our One Health expert whether veterinary clinics should be notified as to unexplained animal deaths, and potentially they have a reporting mechanism that can go to the top on unexplained deaths. So that's really helpful. But yeah, we have included some One Health elements in the toolkit.
Thank you. Yeah, go ahead, Alice.
Yeah, just to mention that, we thought about this, but we were like, okay, should we not? And so quite frankly, it's an area that, we temporarily landed on perhaps, it shouldn't come in at this point. However, I take note of it, and if it's an issue, an idea that participants feel should actually be part of the indicators, that we can absolutely include, especially that we say that, all this is contextual. We may find some communities actually that may want to monitor, the animals that may be dying in the communities or those that are affected. Yeah, I know there may be issues around attribution, but yes, that's something that can come in at a later point. Thank you.
Thank you, Alice. I think I'd also like to get inputs from our participants, because I know we have colleagues from Prezode who usually join us in our lessons. So maybe do we have a representative from Prezode who can also share their insights? If not, we can go to Pamela first, and then Hamidou is raising also their hand. Go ahead, Pamela.
Yeah, good evening, and I'm Pamela from Homa Bay, Kenya. I work for, I have an organization, a community-based organization that is empowering community on TB advocacy and people living with HIV and AIDS. It's always I've attended the sessions that maybe the outreaches that the government of Kenya has been doing, and we have always seen that most of the people who are being mobilized to attend these sessions are mostly the healthcare workers. I don't know whether you have included an indicator that can also track if we are reaching the community with the messages, and maybe how we can measure this, maybe do a monitoring and evaluation about it. Thank you. That was my area of concern. Yeah.
Thank you, Pamela. I think it's a question directed to Alice.
Absolutely. I do agree with you, Pamela. Yes, as indicated to you, there are indicators that we are looking at for the facility level, but also for the community level. At facility level, for sure, we will be focusing on knowledge and information communication for the health workers or health providers, as well as for patients who are reporting at the facility. And then at the community level, it will be much more information for community members. So yes, we are considering that. Thanks,
Thank you,
Pamela.
Alice. All right. FIFA, would you like to add to that or no? Oh, okay. So let's proceed to the question of Hamidou. Hamdou.
Okay. Good evening or morning, everyone. I will speak French.
So we'll ask the help.
Okay. It is okay. I can go.
Yeah. Please go ahead. Our French translator will also translate.
Ok. Donc, merci beaucoup vraiment pour ce webinaire. C'est vraiment juste une contribution. Et puis poser une petite question parce que nous, au niveau du Burkina Faso, moi, je suis le directeur exécutif national du réseau accès aux médicaments essentiels au Burkina Faso. Nous avons le CLM qui nous met en œuvre à travers donc l'Observatoire citoyen sur l'accès aux services de santé, qui est assez intégré avec beaucoup d'expérience. Et nous avons déjà quand même fait un processus pour intégrer les indicateurs PPA dans notre CLM depuis un certain temps. On avait déjà des indicateurs PPA, donc surtout liés à la vaccination, puisque nous suivons déjà la situation de la vaccination donc, des enfants. Nous essayons donc de suivre comment les choses se passent. Et actuellement, avec l'appui donc, du Fonds mondial et de ITPC, nous avons intégré d'autres indicateurs sur la préparation aux pandémies, surtout la question donc, de l'hygiène et assainissement, qui est extrêmement important en matière donc, de préparation et réponse. Mais également, nous avons pu intégrer les questions de disponibilité des services pour la tuberculose et le VIH. Et ce sont quand même aussi donc, des indicateurs PPA qui peuvent être intégrés très facilement au niveau donc, des CLM. Nous avons fait une rencontre avec vraiment donc, les groupes communautaires concernés, avec les décideurs et autres. Et c'est ensemble que nous avons fait une identification des indicateurs clés nécessaires en fonction aussi donc, des niveaux de préparation donc, du pays. Parce qu'au Burkina Faso, on a un rapport GIE qui a été fait en 2017. Donc, c'est sur la base donc, du rapport donc, du niveau donc, de préparation du pays que nous avons identifié les indicateurs qui sont les plus pertinents pour le pays, pour pouvoir aider le pays à pouvoir effectivement suivre. Le défi à l'heure actuelle, c'est comment vraiment donc, former les acteurs parce que l'un des défis en matière de PPR, c'est la compréhension donc, des communautés. Et je ne sais pas au niveau donc, du consortium, est-ce qu'il y a eu quand même des modules qui ont été développés pour mieux renforcer donc, les capacités des communautés sur donc, peut-être donc, les PPR, vraiment les communautés à la base parce qu'on n'a pas une très bonne compréhension parfois de comment les choses se passent. Et ça, c'est un peu des défis que nous avons actuellement. Sinon, on a pu intégrer et on est en train donc on a démarré donc la collecte des données. On a fait aussi une cartographie des parties prenantes pour le plaidoyer parce qu'il faudra bien utiliser les données après pour faire le plaidoyer. Il y a une cartographie donc des différents cadres et instances donc de plaidoyer qui a été fait, et ça c'est vraiment donc très intéressant. Donc l'outil qui a été fait va nous aider encore à mieux peaufiner ce que nous sommes en train de faire déjà au Burkina Faso. Merci.
Okay, thank you, Hamdiu, for your sharing. Amazing work that you're doing in Burkina Faso. And glad to hear that PPR indicators are already being integrated in your CLM mechanism. So he was actually asking about any efforts on building the capacity of different actors. I think maybe Rain can also chime in on this question because she is also looking at the development of different community guides. But any thoughts from our speakers, Alice or FIFA?
So just that, according to the translation, there was is there a module of training that's going to be included in the toolkit? In our toolkit, so we are including a case study on how Burkina Faso has done a good job. But I don't think we've been asked to add a module for training in particular. But certainly we will have more inserted on what the IHR is, what the stakeholders, who the stakeholders are, advocacy messages, that kind of thing. But it's not the same as a training module, but perhaps that can be flagged as what's useful for the future and more suitable for Rain to feed back on, I think.
Yeah, thank you, FIFA. Alice, go ahead.
Yeah, I just want to mention that we too were not asked to do that, but we do identify the need for that. Really, yeah, it's so much needed. Because honestly, the terms are so many and they are relatively new to several individuals. There's many of the terms that many individuals are used to are those mainly related to HIV, TB, malaria. Those that are related to PPPR, there are quite many not very well known, and so there's definitely need to increase awareness, knowledge on all these terms and the different concepts. Actually, the one thing that we know we have indicated in the resource tool is that that sensitization is necessary, but then we need to link it to a resource actually that indicates all these concepts and ideas and terms. And so maybe once Rain points us to that, then we will make the linkage in the resource tool, or if not, then we will see how best we can incorporate that. Over.
Thank you, Alice.
Thanks both for the responses. Definitely, the two resources were not made to be a training toolkit per se, but they are informative guidance that can support countries, including our TA providers in providing the TA. If there's a need, for example, for Burkina Faso, I understand that you underwent also a workshop to co-develop, and there was a certain training agenda that was developed by the Metal Consortium during that time. It definitely merits if there's a need to develop a more localized training toolkit that you plan to use for rollouts. And I think that can be requested through a technical assistance approach for a follow-up TA in Burkina Faso. I know that TA is currently being under wraps right now, and we can have further discussion together with the TA providers from the Metal Consortium to discuss any other needs in Burkina Faso after this one. Thank you. I think the floor to Maureen now.
Okay, go ahead, Maureen.
Yeah, not a question per se. Can you hear me?
Yes, we can.
All right, okay. No, yeah, I just wanted to thank our speakers for sharing the resources. I think that those resources are very timely, and I'm sure they're going to help our CLM implementers as they're still trying to navigate how to incorporate PPR into CLM. I just wanted to comment, I think make a small comment on the animal health. I think considering the increasing risk of zoonotic diseases, I think definitely it's an area that we can't ignore. And when you look at most of them across many countries, and you look at the performance of veterinary services reports, those assessments they do when it comes to animal health, you see that the performance is quite poor. And I think in many countries, most of them, they lack the capacities. So I think it's an area that definitely I think we should be paying attention to. And I understand, I completely agree with Aris that I know they thought about that. It's I mean, it's a new area altogether. So maybe to some extent it might be a bit tricky to say what's our entry point. But I think a good entry point would be even just, because I think I've noticed within for both tools, we are looking at a human resource. So I think a good entry point for the animal health, it would be from the HR point of view, from the HR angle, because even within the animal health, they also do train their volunteers, community volunteers, and those volunteers play a very, very key role in monitoring what's happening across communities, reporting those deaths and all that. So I think that could be a good example and a good indicator to start with, as much as we know that it's a very different area on its own. Yeah, but I just wanted to agree with the person who spoke, who asked that question, to say, indeed, it's an important area for us to consider. Yeah, I just wanted to add that. Thank you.
Thank you, Maureen. I saw Alice and Rain giving a thumbs up. Would you like to add on it, Alice, or comment on the statement by Maureen?
Yes, I do. So initially, like I indicated, it's an area that we talked about and we were like, we were not sure. But given that it has come out of this conversation, and the point of entry was actually it's like a silver bullet for me. As we develop these indicators and make proposals, I think that will be very good for us moving forward. So thanks, Maureen. We appreciate.
All right. FIFA would like to add. I saw your
Yeah,
chat.
just to say that our advocacy toolkit does include One Health and animal health, but it's mainly tracking if animals are sick or there's unexplained deaths. But we can certainly approach it also from the human resources aspect, as in, whether there is that kind of expertise at the local and district level. So it is something that we can include because that is one of the core capacities anyways. So thanks so much for that suggestion, Maureen, and we'll definitely include the human resources aspect as well. Super helpful.
All right. So thank you, everyone. I think we're already up for time. So thank you for your active participation and to all our speakers who have joined us today. So I'd like to present these certificates of appreciation to our speakers, to Alice Kayongo. So let's give her a round of applause virtually. Also to FIFA, who is actually our second time having you speak in the lessons, but thank you for being generous with your time always. And then also to our country implementer sharers, Christine, Ma'am Sidu, as well as to Lawrence Konyongwa. So thank you for sharing your experiences here at Lessons 8. And now I'd like to take this time for us to get a photo. So if you're comfortable, please do turn on your camera so that you can be included in our photo opportunity. So Jeff will give us the cue.
Thanks, RJ. Let me just wait. We've reached more than 100 today. So this is the first time that we've reached more than 100 since we started lessons. So congratulations, everyone. All right. I have multiple panels, 4. So let me start with this one. 1, 2, 3. Give us your best smile. 1, 2, 3. Next one. 1, 2, 3. One more. 1, 2, 3. Okay, another one. 1, 2, 3. And one last. Okay. 1, 2, 3. All right. Thank you so much, everyone. Back to you, RJ.
Thank you, Jeff. And as before, we would like to get your inputs on how we did for this webinar. So you can scan this QR code and it will lead you to the webinar 8 evaluation form. And I'd also like to share the social media channels that we have. So if you want to follow Upcaso on Facebook as well as Instagram, and we also have Africa Coalition on TB platforms here. So you can follow them on X as well as Facebook. So again, please do scan this QR code. Your feedback is very important so that we can continue improving on our lessons. And for those who want to be updated and also get the resource materials that we had earlier, please do join our WhatsApp community group. So again, you can scan this QR code and it will lead you to the link going to the WhatsApp community group. Okay. So I think that's it. So thank you everyone for being participative, and also congratulations to all of us. We had the highest number of participants for this lessons 8. So again, thank you.
Thank you.
So just flash the evaluation form so that before you leave, you can take note of this.
Thanks, RJ. And bye.
Thanks, everyone.
Thank
Thank
you also
you.
to
Yeah,
Rain for
bye.
leading this webinar, and also to our translators. Thanks, Jeff, for also the guidance on this.
You.